The Edwards Syndrome Association is a 100% volunteer 501c3 nonprofit organization dedicated to advocacy, equal care, education, and rights of people with Edwards syndrome. The ESA strives to empower parents to advocate while working to help break barriers for those with Edwards syndrome. This podcast is for educational purposes only. For all medical advice, please speak with your medical providers. Thank you for joining us and for breaking barriers with us.
Welcome to the Breaking Barriers podcast, where we talk all things Edwards syndrome, special needs, therapy, disability, and everything in between.
Welcome to another episode of the Breaking Barriers podcast. I am Gina Polisek and will be your host for this episode. I am joined by my co-hosts Kelly Peterson and Crystal Simpson. Today, our guest is Dr. Iverson from University of Kentucky Children's. Dr. Iverson is an ENT and has been on previous episodes. Today, he joins us to discuss the topic of trachs and Malacia. I will hand it over to Dr. Iverson to give a brief introduction before we get into our conversation.
Well, thank you again, Gina, Kelly, and Crystal, for having me on this podcast. Certainly has been a lot of fun working with you guys and discussing these, I think, very important topics. So once again, I'm pediatric ear, nose, and throat. I've been here at the University of Kentucky for 10 years, boarded in otolaryngology, as well as having a complex pediatric otolaryngology sub-certification. I'm the chief of pediatric ENT here at the University of Kentucky and vice chair for clinical affairs in our department. And so yeah, it's just been a pleasure to meet some great folks and work with children and families in the trisomy 18 community, and definitely happy to keep answering these questions and get information out there to your listeners.
We're very glad to have you. This is now our fourth episode with you, so it's wonderful to get your knowledge and expertise out there to our community. So let's kind of jump right in. So what is a pediatric tracheostomy, and in what situations is it typically performed?
Yes, very good. So, tracheostomy, it's a procedure that has gone back many, many, many years. And the safety of this procedure has improved significantly, even within the past kind of 40 to 50 years, especially in children. This procedure has been studied heavily, extensively, when to use it, what kind of indications, how to manage folks who have had this, how to teach and train families, how to teach and train healthcare providers, nurses, respiratory therapists. So there's just been a lot that has gone into pediatric tracheostomies here, even very recently, where there used to be a high mortality rate for folks undergoing tracheostomy tube placement, but that has really decreased in recent decades. And so, but what it really is it's creation of an alternative airway by making a hole in the anterior front of the neck that communicates with the windpipe. So if you feel in your neck, you can kind of feel some harder structures just right here in the front. Those harder structures that are up higher, kind of the Adam's apple, that's the Adam's apple is what we call the thyroid cartilage. That is right at the level of the vocal cords. So if you were to open that up like a book, at the bottom of it, you'd see the vocal cords. So, and that's kind of the opening to the trachea or the windpipe. And so what we do with the tracheostomy is we make a hole below the level of the vocal cords, usually within the second to fourth rings of the trachea, which are cartilaginous rings, kind of these C-shaped rings that perform or that provide support to the trachea or to the windpipe. And we make a hole through those rings and open that up to the outer skin here in front of the neck. And so, and then generally there's a tube placed as well, just to kind of keep that hole open, keep it patent, allowing exchange of air through that hole, allow the ability to manage secretions, suction through that hole to manage either aspirated secretions or just secretions. We don't really think about it in general, but we produce a lot of secretions from our lungs that we just, without thinking about it, we just kind of cough and swallow and clear. Some folks don't have the ability to do that very well. So that's another important aspect of a trach as far as what it can do. And then it can also develop or deliver pressure and oxygen directly into the lungs, kind of bypassing, the need for a breathing tube or an endotracheal tube that would be coming, out of the mouth or the nose. And so that is essentially what a tracheostomy is. Reasons that tracheostomies are performed can be multiple. Common reason for a child having a tracheostomy is certainly their lung development or function. So children who are born premature or with other neurologic conditions or cardiopulmonary conditions can have just less than ideal exchange of gases to basically deliver oxygen to the body or to remove carbon dioxide from the body. And so they can have what's known as a chronic respiratory failure. And so they basically need that ventilatory support. They need the pressure that helps deliver oxygen. They need the rate, so kind of the breathing, the mechanical breathing, in order to remove things like carbon dioxide. And so if that's not able to be done on a patient's own, we talked about sleep apnea before, either because they don't have the drive to breathe, or they don't have the ability to breathe through their native airway, or basically if the lungs haven't developed, especially in the area of prematurity, where those lungs haven't developed well enough, we call it bronchopulmonary dysplasia, just enough to be able to exchange those gases appropriately, and you need that prolonged ventilatory support. Well, that's where a trach can be helpful for folks. And so you can connect, rather than connecting a CPAP or a BiPAP to a mask or hooking up a vent to a tube that goes into the mouth, that can be connected to the tube that goes into the neck, the tracheostomy. And, that's something that children can they don't have to be sedated once everything heals. So they have more freedom to kind of move around. You don't have to, have a breathing tube placed, which generally requires sedation. So if kids have that prolonged need for ventilatory support, they are much able to grow, develop, learn, move around with that trach in place than they are otherwise. And the other reason that many times trachs are placed are for like chronic aspiration, for pulmonary toilet. So basically, if kids don't have the ability to either protect their airway from their own secretions or, what they're eating or things like that, where there's just chronic aspiration of material down into the lungs, that can cause a chronic set up a chronic infection of the lungs. It can worsen the function of the lungs. So sometimes there's a need for just that, what we call pulmonary toilet, just to kind of clear secretions, suction them out, those types of things. And then, we touched on the obstructive sleep apnea in the past. And so the tracheostomy can also be kind of the gold standard or the kind of the end surgery, more or less, to treat severe obstructive sleep apnea, where if we can't modify or adjust things above the level of the windpipe, then we can kind of bypass all of those things by getting an airway right into the windpipe, which basically cures obstructive sleep apnea. Other reasons for a trach sometimes, and we'll get to this a little bit later, but things like tracheomalacia or bronchomalacia, which are where the airways themselves within the windpipe and the main pipes that go to the lungs are collapsing. And sometimes you need that trach in there to help hold things open, to deliver pressure in order to maintain breathing and ventilation. So those are the main reasons. Other reasons, I guess, if sometimes there can be where um, just the airway is narrowed for one reason or another, either congenitally narrowed or because having a breathing tube placed in and out multiple times can cause some scarring of the airway. Again, the trach is a way to bypass all of that. So those are some of the more common reasons as to why trachs are placed.
Okay, and I know we touched on this on the previous episode with you for apnea, but could you just give a quick high level kind of rundown of alternative treatments or interventions that are typically considered prior to tracheostomies?
Sure, yes. So kind of the non-medical, or the non-surgical options would be things like oxygen or CPAP or BiPAP, anything that kind of creates a column of air or extra flow to help keep those airways open. Versus, if we have other areas of obstruction, whether it's in the nose, the throat, the tongue, the voice box, any other area of floppiness or low tone or obstruction within that upper aerodigestive tract, there can be things like opening up the nose, turbinate reduction, adenoid surgery, tonsil surgery, tongue-based surgery, trimming up the airway, which we'll talk a little bit about with laryngomalacia. So some other surgical interventions to open up that airway can help address obstructive sleep apnea prior to a trach.
Okay. And for those that are listening, if you want a higher level, more in-depth kind of explanation to some of those things that Dr. Iverson just touched on, you can refer back to our episode on apnea with him that was just released a few weeks prior. He definitely gets into kind of the nitty-gritty a bit more on those topics if you want to learn more. What does immediate post-operative care
Mm.
look like for a child with a new trach?
Yeah, so that's really kind of one of the more critical times um, to be very careful, where complications can occur is in that immediate postoperative time, usually within a 5 to 7 days. So what we have is we've got a fresh wound in the neck. Some people will make a vertical incision in the neck. Some people will make a little horizontal. Usually in children, make a vertical. It's easier to get down to the structures. It all heals down as a circle anyway, but allows me to stay midline in children's necks. But there is basically the skin, and then between the skin and the windpipe, there's soft tissue, there's the thyroid, there's some muscles. Basically, there's potential space for either the trach to go into as a false passage or for air to be blown into as a false passage. So really that critical time after a trach tube is placed is giving adequate time for basically the skin of the neck to kind of heal in continuity with the inner lining of the trachea. And thankfully that happens pretty quick, honestly. And because the body's so good at healing this. So in general, kids are kept pretty sedated, trying not to move around too much for that first 5 to 7 days. We're very particular about kind of who manages the airway, who's looking at the airway, who's inspecting the airway, having appropriate tools in order to address an airway or replace an airway if it were to get dislodged. We've had instances where kids are getting a bath in the middle of the night, and the trach comes out, and it's a fresh airway, and there's it takes quite an effort to get that trach back in and get into the right place, because there is the potential, if the trach goes into what we call a false passage, which is somewhere between the skin and the trachea, you can be blowing air just down into soft tissues. That air can go up through the neck, where we call it crepitus in the neck, where you get a bunch of air in the neck. It can extend down into the chest, where you can get air in the chest. Sometimes there can be an issue where the lung collapses. So it's a very critical time in that postoperative period after placing a trach. So, we've got sutures. Many times what I'll do is I'll have kind of these belt and suspenders where I've got permanent sutures that go down to the trachea itself, so that if that trach were to come out, I can lift up on those sutures and I can basically be looking right down into the windpipe in order to replace the trach. The other thing that I do is I do these maturing sutures where I basically suture the skin of the neck down to the windpipe to try to encourage that healing as quickly as possible, so that there's less of a chance of that false passageway. And then the other thing that we typically do is have a nice secure tie around the neck, with some padding underneath just to protect the skin. But yet, we want that trach to be quite secure. Many times there'll be some criticism as to, oh, that looks too tight. And my rule of thumb is always want to put one finger underneath. If I can get a finger underneath that trach tie, then I'm feeling comfortable with it, because I want it secure. I don't want that trach to come out, just in the just kind of the typical things that happen right after a tracheostomy tube placement, just so that we maintain safety there as well. And sometimes some extra sedation and pain control certainly is given afterwards, just to kind of prevent agitation, prevent kids from pulling at the trach, prevent excessive movement that could potentially result in dislodging of that trach. We generally have a lot of equipment at the bedside, kind of maps or profiles of what the airway looks like, so that we can say, well, if this trach comes out, this is what we can, replace the airway with, just so that we maintain, optimal safety for a patient undergoing a trach. But usually after that first trach change, I generally like to do the first trach change myself, so that once I've changed it the first time, I can make sure everything's healed well. I feel like we're out of the woods for developing a false passage. Then we can really start kind of letting up on some of the sedation. We can, start having families, learn how to change the trach, take care of the trach, do all the things that are needed to care for the trach and the patient with the trach going home, because it's a lot. There's a lot involved. There's a lot of equipment, especially if you're on a ventilator. There's a lot of good resources and medical equipment, but it's a lot of coordinating of all those things as well, that are important to do after that.
Certainly. And I know a lot of people with trachs have to go home with like nursing care and stuff like that. So there's
Right.
also a lot of like coordinating, making sure that there's proper, people beyond the parents to help,
Right.
for kids that need that 24/7 observation and care. So yeah, there's definitely a lot that goes into it. We definitely know that. So we appreciate you sharing all that information.
Sure.
How does a tracheostomy affect how a child speaks, eats, plays, basically all of those things?
Yeah, that's a very good question. And I would say, you know, depending on the situation, it can either affect it a lot or affect it very little, those things. A lot of it depends on what that trach is needed for. So going back to, if the trach is needed in order to provide ventilation to the lungs, hi. Ventilation to the lungs, exchange of air, being on a ventilator. Well, many times what that involves is using a cuffed trach. You may have heard of cuffed versus uncuffed trachs. Well, the cuffed trach basically is when that tube goes into the windpipe, there's a little balloon that's either filled with water or air that you blow up, and that basically seals almost like a gasket. The we got all the kids on now. I love it. That kind of seals with a gasket just so that we can deliver higher pressures down into the lungs without a lot of air escape. So that's where that cuff trach, if that's used, it basically does block air and prevent air from going back up through the vocal cords. So if you have that cuff trach, it's a lot more difficult to speak, especially when you're on the ventilator. Now, over time, sometimes as pressures come down, the need for delivering such higher pressures into the lungs goes down. We can decrease that cuff or eliminate the need for that cuff. And then we can use specialized speaking valves that are kind of one-way valves. Whereas if a speech is initiated, it'll actually close off that airway for air to come out through the trach and kind of make air go up through around the trach through the vocal cords in order to vocalize and in order to speak. So there is, and that's usually called a Passimura valve that can be done in line with a ventilator. But if a ventilator is not being used or is not needed, that valve can also be, just placed on the end of a trach. And that can help with the voicing. Even just putting your finger over the trach and talking, will improve,
Yeah.
the clarity of the sound coming out, because it forces air up around the trach, up through the vocal cords, as long as there is a good pathway around that trach to do that. And that's why we put that trach down below the level of the vocal cords, so that, when the time is right and as we're able to, we can help the child speaking. As far as eating is concerned, that valve actually does help with eating as well. When you think about it, when you drink something, you are protecting your airway. So you kind of have to hold your breath. We do it without even thinking about it, but you hold your breath, you close your vocal cords, you kind of have that increased subglottic pressure, which is pressure that you kind of build up below the vocal cords that helps with the swallowing, helps things kind of get directed back down into the food pipe. And so that valve can also be used while eating, and, working with speech therapists and stuff, we can optimize that as well. And as far as playing, I've seen kids, I've seen kids even with ventilators on, where they have trachs and a home ventilator, and parents are like chasing after them, with their ventilator and the hose, and, just so that they're not ripping the trach out, because once they start going, they're going and
Yeah.
running. So sometimes it doesn't really affect them at all, as far as that, if they're able to kind of get to that developmental stage where they're walking, running, doing all that type of stuff. Certainly, we have to be careful with any sort of water activities, right? Because, there's not a good way to protect, especially bath time, getting in bodies of water, because you can't really hold your breath. You just got a way for water to go right down directly into the lungs. So you definitely have to be careful when we're dealing with that type of thing.
Yeah, it's amazing what all the things that you can still do with a trach.
Yes.
It truly just shows that I know a lot of parents get really nervous when a trach is brought up, and, they just think about all the things that their child may not be able to do.
Right.
So I think it's really important to highlight, all the things that they still can do with a trach. And, it's just a matter of finding kind of your rhythm with it, and,
Right.
what works for you. And they really don't limit the opportunities are still endless, I feel like.
That's exactly right.
And that just speaks to just the advancements and, things that are out there now for people medically, which is really cool. I
Yeah.
also wanted to add to, thanks for bearing with us with the children.
Oh, no, I
Uh,
love it. I think it's great.
it's a good time to add that we're parents first, so we're just
Yes.
kind of doing this in the pockets of our days, and the kids are starting to get a little restless. So thank you for bearing with us. And for those that are listening, we if you don't have the video up, Dr. Iverson was just saying hi to our kids because they appeared on the video with us. So we now have two more co-hosts.
That's right.
Um, but can you tell us a little bit about, do you have any information on statistics and how common trachs are with people with trisomy 18?
Sure. And I will say that has been a changing number over the past 30 years. About 30 years ago, it was only about 1%, which is pretty small. But certainly, as technology is improving, and life expectancy that we're seeing is improving with trisomy 18, and then things that we can offer folks and that we should offer folks. We are seeing higher rates of kids with trachs, even up to 17% in some literature. Now that may be higher in folks who are having undergone cardiac repair and other things like that. I saw one report as high as 2/3 of kids who undergo cardiac repair can have a trach. But I think this is and that may be just because of the location and the quaternary center where that person was. But I think in general, it's about 17% looking across the board from what I can tell from the literature.
Okay. Yeah, I mean, that seems pretty, I've never actually heard of like a percentage or anything, but kind of just generally looking at like the community, I would say probably 1 in 5 kids is probably a pretty good,
Yeah,
pretty accurate statistic, kind of just from who we all know and everything like that. So
sure.
that's good information. Have you done any decannulations for people with trisomy 18?
I have not.
Okay.
Yeah.
I mean, I'm sure they're probably not super common. Just kind of going off of that statistic that you just said of 17%, and then, actually getting to the point of, being able to decannulate is probably pretty rare. But certainly has happened. I know of a couple, I
Yes.
think.
Yeah.
And for those that are listening, decannulation essentially, Dr. Iverson, you can chime in too if I'm butchering how I'm saying this, but it essentially means you're at a point where you no longer need the trach and it can essentially be removed.
That's right. And I will just say that I have not, but I know that has been the case. And so in fact, just to kind of say this, I'm not aware currently that I have any patients with trisomy 18 with trachs either. So I'll just say that as well. I do have a number of current trisomy 18 patients that I'm following, but unless I'm forgetting someone, I apologize if that's the case. I don't recall of someone that currently right now has a trach, which is great as well. But yes, so for decannulation, now I do decannulations, almost, definitely, I mean, all the time, right? So I don't know, it kind of goes in waves and seasons and things like that. But so I decannulate folks all the time with trachs. But the qualifications that we look for is improvement of their pulmonary status, so where they no longer are in need of a vent. So that's kind of what I'm doing. I'll survey kids after a trach every 6 months to a year, where I'm kind of seeing where they are in their vent settings. They generally work with pediatric pulmonary who manages the vent. And once we see that need for the vent come down, I generally like to see them really waiting for the pediatric pulmonologist to say, yep, they're ready to come off the vent, or they're actually off the vent. So once we have no longer a need for that, the other aspect that we look at is their airway appropriate to come off of the trach? Because as we talked about before, many times a trach can be a treatment or a solution for obstructive sleep apnea. So I want to make sure that, by me taking out this trach, kids are not going to all of a sudden have some, very severe obstructive sleep apnea. So many times that will involve either a sleep study, as we talked about in the other podcast, but we can do a sleep study with the trach capped, where we can have a small trach, so we know that we have air going around it. We can put a cap on it where there's no air actually flowing through the trach itself. And we basically do a sleep study to see, how much sleep study would this, individual, or how much sleep apnea would this individual have if they essentially didn't have a functional trach. Or, and so that gives us an idea. And if there is some sleep apnea, then we kind of go back through kind of our protocol for, well, where are they obstructing? How can we relieve obstruction? How can we optimize their sleep apnea in absence of this trach that's just kind of bypassing everything? The other thing that we look at is just kind of what the airway looks like. So when we do a trach, we're certainly making a hole into the windpipe. Certainly there can be some scarring, there can be some granuloma formation. So we basically want to make sure that that the airway up above the level of the trach is wide open. And whether that just means, hey, we have to trim up a little bit of tissue, some granulation to open up the airway, or if it means we have to do a little stretching of the airway to get it to appropriate diameter, or sometimes we do have to do airway reconstruction, where the airway is too narrow for that person's age for us to just remove the trach. And in order to get where that trach needs to be removed, sometimes it involves doing what we call an open reconstruction or a laryngotracheal reconstruction, which many times can involve, if it gets to this degree, where we split the airway, and then we can take cartilage from different parts of the body, usually the rib, and then we can take that rib and use it to expand the windpipe above the level of the trach in order to have a wide open airway, and that rib cartilage just kind of incorporates into the other cartilage of the airway. And then many times with that, we're able to get the airway or the tracheostomy tube removed. So it has to be pulmonary standpoint, and then also from just kind of an airway obstruction standpoint. We don't want to just remove a trach until we've fully assessed and addressed any potential airway obstruction.
Certainly, yeah, that makes sense. You don't want to be in a position of having to put it back in again.
Right.
I assume that's possible, but certainly probably not an ideal situation.
It is
Um,
possible. I'll just say this because sometimes when I'm taking out the trach, that hole that's been in there doesn't close up right away, especially if we've had a trach for a number of years. That hole is not going to just immediately close up. But what we'll do is I'll just leave it open. It'll kind of slowly come down. And if we've done well, then usually about 9 to 12 months later, I'll do a procedure to close that up if we've done well. But that way we've got a good amount of time to where, hey, if that trach needs to go back in, it's a lot easier to dilate up a little hole that we've had previously than to do a whole other, surgery to put a trach back in. Sometimes that is necessary, but not always.
yeah, that makes sense. What is pediatric malacia and how does it affect the airway?
Yes. So Malaysia, the way I just describe it in general is just floppiness of the airway. And so floppiness or some sort of dynamic collapse of the airway, or it could be from some type of compression of the airway. But in general, it's this this floppiness of the airway. And where it can affect is the larynx, and we call that laryngomalacia. So above the level of the vocal cords, we've got this tissue, the epiglottis. I tell folks it's a flapper valve that keeps food and water from going down the windpipe. That's connected to some other structures called the arytenoids and some supraarytenoid tissue. Those help move the vocal cords in and back open and shut. They're kind of these hinges, and there's tissue, muscle, and cartilage, and just some mucosa that make up that material up there. And there's a level of tone to it, which comes from neurologic tone, but it also comes from kind of structural tone or integrity of that trachea. If you feel your windpipe here as an adult, you're like, well, this feels pretty firm, but certainly in a young child, that cartilage is much, much softer, much floppier. But it really is both tone, so neuromuscular tone, as well as just the structural integrity of that. So if there's malacia above the level of the vocal cords in the larynx, that's called laryngomalacia. If there's malacia that's below the level of the vocal cords, and again, it can be related to muscle tone as well as structural integrity of the cartilage. If there's collapse of the windpipe in the level of the trachea, that's tracheomalacia. If there's collapse in the level of the bronchi, which is where the that main windpipe, the trachea, will separate out into the right and left mainstem bronchus or bronchi. And those also have muscles and some cartilage around it that helps keep its integrity. But if that is floppy and collapsing, then you can get bronchomalacia at that level. So those are really the levels of malacia that you can see. And it's very important to kind of hone in onto what type of malacia we're dealing with, because they're treated in different ways. Certainly laryngomalacia, which is above the level of the vocal cords, is treated a lot differently than that tracheobronchomalacia. And then we also look at, what could be causing, what are other factors that can play into that malacia as well.
How common do you feel malacia is in children with trisomy 18?
It's very common. So, just from a neuromuscular tone standpoint, where you kind of have that hypotonia of the muscles above the vocal cords. So the laryngomalacia we see is probably about a third of kids with trisomy 18 will have some degree of laryngomalacia, varying severities. And then about half of children with trisomy 18 will have some degree of tracheobronchomalacia. And the way you can kind of tell the difference between the two is it really is kind of the phase of breathing. So if you think about noisy breathing when you're breathing in, so that's inspiratory stridor. What happens is if you got air flowing between that floppy tissue above the vocal cords and that air flowing at a faster rate, will create this little Bernoulli effect that'll kind of create a low pressure system and draw that floppy tissue in towards each other, where it collapses and can rub together and cause the noise. So it's like that inspiratory stridor or inspiratory squeak where I'll just kind of make the sound. It's like this, you may have heard that, or sometimes there's like a congestion sounding. People will tell me that they feel like there's something there that they just can't clear. And that's just kind of from that low tone, low sensation, just kind of secretions and tissues rattling around up there. That's the laryngomalacia. Now the tracheobronchomalacia, usually you hear that noise more in the expiratory phase. So when you're breathing out. So when we breathe out, especially forcefully, we're kind of compressing our chest wall. And then if that windpipe, either in the trachea or the bronchi, are getting compressed, they will collapse down. So you hear more of that noise in the expiratory or the breathing out phase. And especially like with coughing, like if you'll hear that barky coughing, that can many times be tracheomalacia or bronchomalacia. And it can be harder for secretions, especially with like an illness or a cold or aspiration or anything that would contribute to that increased secretions. It can be harder to clear those secretions and cough them up. So that's more of the tracheobronchomalacia.
And what interventions have you seen for people with trisomy 18 that have malacia?
So a lot of it depends on whether it's that above the vocal cords or the laryngomalacia versus the below the vocal cords, that tracheobronchomalacia. So with laryngomalacia, I'll just start there. Sometimes it can be just treating anything that's going to cause excessive floppiness or inflammation or low tone of that supraglottic airway or the airway above the vocal cords. And many times we see reflux playing a role into this. So just like there's low tone of the voice box, there can be low tone of that muscle that kind of keeps, gastric material down into the stomach. So reflux can come up. The acid content of the reflux can actually cause some just some changes to the voice box where there's less of a sensation. And it actually is this feedback loop that people have looked at where there can actually be lower tone of the voice box. So many times the reflux goes hand in hand, doesn't necessarily cause laryngomalacia, but can worsen laryngomalacia. So we really want to use some techniques that kind of treat reflux, manage reflux, whether it's, keeping kids upright so that they're less, prone to like physically reflux, or treating with some sort of antacid medication that will reduce the acid content of that reflux. So we're less likely to have worsening of that feedback cycle where there's lower and lower tone with reflux. So that's one option. And many times that will help improve, but in some instances, that floppy tissue of the larynx, we do have an option to trim that up with a surgery, and it's called a supraglottoplasty. So that floppy tissue, we just trim with teeny tiny little scissors. We do it all through the mouth, helps open up that airway, prevent that collapse of that tissue as we're breathing in. So certainly if it's really, really severe, there can be a tracheostomy that's performed. But most of the time we're able to address that laryngomalacia with kind of a lesser invasive surgical procedure, if a surgical procedure is needed. As far as malacia that occurs below the level of the voice box, so if we're talking about tracheomalacia, bronchomalacia, there can be, oxygen, some type of positive pressure support to kind of keep that open. Certainly chest physiotherapy with respiratory therapists, because if we're not able to clear secretions as well as we typically are, then there's that need for like either vest therapy or percussion therapy, that type of thing to help clear. Certainly using things like saline and some Atrovent can help with the airway. Many times you do want to avoid things like albuterol, because albuterol for that tracheobronchomalacia, guess what it does? It relaxes smooth muscle. So if you use a medicine that's relaxing smooth muscle, sometimes that can make tracheobronchomalacia worse. There is a medication called bethanechol that helps with tone of those smooth muscles, which sometimes can be helpful. But sometimes ultimately a tracheostomy can be needed, both as a physical stent, to keep the airway open where it's collapsing, as well as a way to deliver that positive pressure effectively of an air column to keep those airways open.
And do you see children outgrowing Malaysia? And if so, by like what age are you seeing this happen?
Yeah, so I do see folks outgrow Malaysia, but a lot of the time it's not so much an age that specifically, but more so kind of when we see that neuromuscular tone develop and improve, and that can be different for different children, especially if we're looking at children with various severities of trisomy 18. So if we see, prolonged poor tone, it may take a lot longer than someone who is not having improved tone and development. So that is, it's hard to really put a specific age onto that. But I would say just when we deal with kind of typically developing improvement of tone, we see it from 6 months to 18 months. But in children who have kind of baseline neuromuscular tone issues that extend past that, then it can last longer.
Okay. Yeah, that makes sense. I mean, so essentially it is possible to outgrow it. But if that's going to happen, the timing of that is going to be case by case
That's
and
right.
dependent on each child and kind of what they have going on. Um, so that's good information. What advice do you have for parents, managing a child that has airway Malaysia?
Yeah, especially if we're dealing, well, I'll just say this. So number one, it is a cause of some pretty significant distress for families, as far as the way their children may sound, or it sounds like they may be struggling. And I think the first thing is just we recognize that, that can be a challenge and that can be tough. But there's also not like a really good, quick or definitive fix to that malacia. We have different things just depending on whether it's laryngomalacia that we can do versus whether it's tracheobronchomalacia that we can do. But there's not really one single solution that we can say, oh, if we do this, that malacia is going to go away. We're not going to have any issues, and things are going to be fine. Even with the trach, because I've had issues where I've placed trachs before, and sure, it helps keep that airway open for as long as the trach is in there, or for as the long as the distance of that trach is in the windpipe. But below that trach, you can still have collapsing, down there. So that can be a challenge as well. But so just the idea that it's going to take time. There's not going to be a quick fix. There are a lot of things that we can do to optimize. But if we do get that development in tone, we can see improvement over time, but that can take months to even years. So just kind of having that in your mind as far as that's concerned.
Yeah, that's certainly helpful. I mean, I think the bottom line and a big kind of motivator of our organization is hope. It's always important to have hope,
Yes.
that, there are interventions and treatment out there for a lot of these things. And there's also hope that, it could resolve over time.
Mhm.
Now, obviously that's, everybody isn't going to get that, but, it's important to always have hope. So, um,
Absolutely.
is there anything else that you want to kind of add on this topic, Dr. Iverson, before we end? Otherwise, I think you've kind of answered all the questions that we had pertaining to trachs in Malaysia.
Okay. No, I think that's it. I think y'all covered it with the question. So
Wonderful.
thank you.
Well, we definitely appreciate your time. This has been very valuable information, especially since these airway issues are so prevalent and common with trisomy 18. So hopefully those listening, this has been just helpful to you. And thank you again, Dr. Iverson, for your time on all these episodes you have been on. We are certain that this probably won't be the last time that our community will see you, as we hope we can continue, utilizing you to better support us and our community in the future. So thank you so much again. We greatly appreciate it.
You're very welcome, and thank you again for just having me be a part of it. And thanks for my T-shirt and my bracelet, and hopefully the sounds like the walk went well, the walk run, and hopefully that'll continue for years to come, and be involved in that in the future as well. So thank you.
Yes, we appreciate your support.